Hey there, Careblazer. Welcome back to another episode of Careblazers TV. I am so excited about this episode because I have Dr. Klauschie with me, medical doctor who specializes in urogynecology, and I think you're going to find this video especially helpful, especially if you're struggling with any type of repeat UTIs with your loved one with dementia. Now, before we get into the interview, if you haven't already subscribed, hit that red subscribe button on your screen. So before we get started, Dr. Klauschie, why don't you tell the Careblazers out there a little bit about yourself?
Well, again, thanks for having me. I really appreciate it. This is something that I'm very passionate about and I love talking about. I am a native Albuquerque, New Mexican, and so I'm a Southwest girl at heart. I'm a permanent resident now here of Phoenix, Arizona. I've had a long path to get here, but it's been an extremely rewarding journey. And I landed working at Academic Urology and Urogynecology of Arizona here in town. But prior to that, I spent 4 years in medical school. At that point, I didn't know what I wanted to do, what kind of specialty I wanted to do. I actually thought a little bit about doing some neurology or neurosurgery since I had a big interest in that. And some of my family relatives have neurologic issues. And then somewhere along the way, I got really interested in women's health, and specifically with OBGYN. Along my way in training, as I got to learn more and more about the little topics, the area of female pelvic floors disorders just really interested me. And what struck me so much about that topic itself was that so many women are out there suffering, often in silence, but sometimes just suffering because it's a difficult topic, to talk about. And if they can find a provider to work with them on these issues, it makes a big difference. It makes a really big difference. So that led me down a track of residency for 4 years in a specialty of OBGYN. And then what brought me to Arizona was the fellowship, which is specifically another 3 years of training in female pelvic disorders. Wow. So it was a long journey, but it was worth it. And I love what I do every day.
Totally worth it. We're so excited to have you. And random fun fact, Dr. Klauschie published her very first scientific article in a journal at the age of 18. For those of you who don't know much about publication in scientific journals, that's like an impressive feat. 18 years old.
So I loved medicine from the time I was little. I knew that was on my path, and literally from the time I was in grade school, I started working on science fair projects. This is a little cheesy history about me. But I started working on science fair projects, and from that point on, I just knew I was going down the path of medicine. And I was lucky enough to connect with some mentors that really wanted, to see me succeed. Mm-hmm. And so, my first, one of my very first science fair projects turned into my first publication at the age of 18. And ever since then, the steps fell into place, and I was able to get where I wanted to be. But it was fun along the way.
That's pretty impressive. And also, a little fun fact, and I promise we'll get into the interview, Albuquerque, New Mexico has my favorite coffee in the whole wide world.
Is that the Pinto coffee or
Piñon?
Piñon, thank you. Yes.
Literally right. On my door, like 10 pounds of it showed up yesterday.
So now that I know that, and since I go back every so often, you may have more because I love it too. I periodically bring some back, and the great thing is there's different flavors too. So you can actually try some of the different flavors.
I've always been the regular Piñon coffee. If you haven't tried it, from Albuquerque, New Mexico, the best coffee you will ever taste in the world. And I was really upset that Trader Joe's stopped carrying it.
Oh, well, we can take care of that.
All right,
actually, that's a fun fact.
See, here we go.
That's a fun fact.
Awesome. All right, interview worth it. We're done here.
We're done.
All right. All right, awesome. How about we hop right into these questions?
Sure.
So, a lot of times, older adults with dementia, and older adults just in general, and even younger people struggle with like UTIs and bladder infection. Can you just go over like basic definition? What is that?
Sure. So a bladder infection is basically the same in our world as a UTI. UTI is short for urinary tract infection. And most of the time when we're talking about a urinary tract infection, it does refer to the bladder and pelvic region, because remember that the urinary system is all the way from the bladder and urethra all the way up to the kidney. So we'll get into that maybe a little bit later, but yeah, bladder infection and UTI are the same, and essentially what that means is that there is an inflammatory process that's caused by usually a virus or bacteria, more commonly a bacteria, that causes the bladder to become inflamed. And just like when you get a common cold, or if you get pneumonia, or you get a gastroenterology virus that causes you to throw up, this bacteria, these viruses will actually cause a set of symptoms related to the bladder. Now again, it can go from the bladder up to other parts of the urinary system, and it can even go into a bloodstream infection. But a classic UTI would basically be defined by an infection within the bladder or the urethral area.
So you mentioned that one of the common reasons for that is like a bacteria infection. Like, what are some common sources that bacteria infection would be coming from?
So that's always a good question. A lot of people come in and ask about that, because a lot of the types of bacteria that end up in the bladder are bacteria that we actually harbor in our own bodies. And I'll give you one example. A lot of people have heard of something called E. coli. And when we think of E. coli, it's often associated with the fecal bacteria or the bowel bacteria. And of course, people sort of, get this automatic response of, oh my gosh, that's, dirt, that's the dirtiest bacteria out there. But a lot of bacteria live with our body in harmony every single day to make our systems even work properly. And the E. coli bacteria is one of those. It's probably the number one bacterial infection in the bladder. And a lot of times it's because we have that bacteria in our own body to begin with. Okay. Well, how does it get down into the bladder? And, one of the interesting things about these bacteria that are in harmony with us is that if that harmony gets disrupted for whatever reason, it can go to places where it shouldn't be. So for instance, if E. coli is common to be found in the intestinal tract and doesn't necessarily create any problems in that location, if it gets to the wrong location, then it will set up a series of symptoms and actually cause a true infection. Where again, if that bacteria is somewhere else where it's used to being in an environment where the body's working harmoniously with it, then it becomes a problem if it gets outside those areas.
Okay. So like, I'm thinking specifically, a lot of the Careblazers that I know, their loved ones with dementia who are still able to somewhat like toilet on their own. They're not necessarily completely dependent on other people, but maybe they're not doing like the best job wiping. Like, that would be one of the common reasons that would lead to a UTI.
It can. It's a little bit tricky because one of the things I emphasize to my patients is that none of us are meant to be sterile. Yeah. Down in the genital rectal area, if we're going to get a little bit personal here, down in the genital rectal area, again, there's meant to be certain numbers of bacteria. Even right now, lying on our skin, there's a common number of bacteria. Again, they're sort of the kind that are in harmony with us. Those bacteria are always present no matter how clean we are. So there's a certain element of emphasizing that you're never going to be 100% sterile. But it is important nonetheless to not miss simple things that you can be doing to keep the area clean, to keep the counts of the bacteria or the sources of the bacteria down. And one common thing would be, as you mentioned, toileting habits. As we get older, sometimes our bowel habits change. We may have constipation more. We may have more loose stools or diarrhea. It may be harder to wipe in areas that are difficult to access to begin with. And so as you have a little bit higher burden potentially of a bacteria that again in low numbers may be okay, as those bacteria burden goes up, certainly it can put you at risk for a UTI. But again, nobody's going to be sterile at 100%. So we're not looking for perfection, we're just looking for improvement.
Yeah, okay. Now, is there something about certain people who are more prone to UTIs than others? Because I've talked to patients who seem to like have UTIs frequently, and some people who maybe have just had one or two, like for the duration that they've been alive so far. Like, what would cause that?
Well, one thing that you know, really stands out to me, and I primarily take care of female patients with my OBGYN background, but my partners in our group are urologists who take care of men and women, but see a large number of men in their practice. One thing to distinguish is that men and women automatically have different rates of UTIs, and they actually have different criteria for when we start worrying about how many UTIs, you know, are going to occur. So the first thing I would say is that, you know, you have to look at what's your patient population. You know, are we dealing with men? Are we dealing with women? My expertise isn't in men, so I don't want to give out too much information on that, but I can tell you that in women, we are more prone to get UTIs than men are. So, you know, if a male patient has some recurrent UTIs, there may be an escalation of care at a little bit of a different level than even a woman. And the reason for that is because women, we're more prone to UTIs just because of the way that we're built, because of our anatomy. Yeah. And with our anatomy, again, getting to the nitty gritty, the rectal and the genital area are really close to each other. I mean, we're talking about within centimeters. Whereas with a man, the rectal area and the end of the urethra, which is located at the end of the penis, is, you know, often 10 or 12 centimeters away. Yeah. So it's a lot harder for those bacteria to come from the genital rectal area, which is the most common reason that we get a UTI, into the penis, which then has to transverse 10 centimeters. Yeah. Versus a woman, you've got this much to travel. So, you know, it's very, very much more common for women to get them. That's the first thing. And then the second thing is when we start subdividing out those categories of people who are getting them, there is actually a workup that we recommend once you've had a couple of UTIs within a short period of time to understand what could be some of the other causes potentially that could be going on. So once we get that workup done, then we can start to, again, better understand, well, what are some of the other risk factors? So just simplifying this down to, okay, we've done the workup, we didn't find anything else, you know, there's no stones, there's no kidney abscesses, there's no bladder prolapse. Those kinds of things are simple things we can check for really easily. Once we boil it down to that, then it comes down to, well, what are some of these other modifiable factors of why this person might be getting them? Because again, none of us are going to be sterile. Yep. You know, you can do a great job cleaning, you can do, you know, a great job with the simple things on a daily basis, but then that person may still be facing them. So as we get older, one of the things that we commonly see, especially in women patients, is a lack of estrogen in the genital rectal area. And when we see that, it actually causes the tissue to thin, and it causes the bacterial counts to become sort of out of balance, so to speak. There's a good number of bacteria that are present from estrogen being there. So as we get older, which of course is, you know, for women after menopause, 50 and older potentially, those estrogen levels are dropping and our tissues are actually becoming dry and cracked and thin. Mm-hmm. And that's going to also modify the immune factors and our defense factors. The blood circulation and blood supply is going to go down in that area. So that's another thing that we can look at. You know, is this a patient that's, you know, in the menopausal area, and do they have some, you know, some anatomic concerns that we could potentially address? So long-winded answer, but, you know, really we want to take those patients that are getting several UTIs in a short period of time and start from the top at the kidney level and work our way down for these, you know, potential etiologies. Yeah. At the end of it, when we don't, again, find anything, which I always tell my patients, look, if we don't find anything, it's a good thing. Yeah. Then we can take those modifiable factors and treat those specifically. Okay. For instance, you know, we can make sure that, again, you know, as many cleanliness types of things are occurring that we can, you know, modify. We can add vaginal estrogen in a lot of candidates to improve the tissue. Yeah. And that in and of itself, it has actually scientific evidence to allow for a reduction in urinary tract infections. We can also, again, treat things like bladder prolapse if we find a bladder prolapse and if that's affecting how the urinary system is emptying. So, you know, once we get through that workup, there's always something at the end of the line that we can potentially do.
Yeah. Awesome. So I think most of us are familiar with somebody getting a UTI, then it leads to an antibiotic treatment, and then, you know, you continue going about the day. But there's definitely other options if somebody's getting frequent in a short period of time that could be explored that I don't think many of you and I wasn't aware of. is there a specific guideline in terms of how many is too many in a short period of time and what that time frame is?
Sure. And as I said, just as a side note, I don't know, since I'm not an expert in men, I'm not sure what that is in male patients, so I apologize. But in women patients, we're looking at two culture positive urinary tract infections in 6 months or 3 in 1 year.
Oh, wow. Okay.
So some of it also depends on what time frame you're looking at.
Sure.
But, obviously, like I said, clearly, 2 in 6 months or 3 in a year. Now, the interesting thing is that with urinary tract infections, once you have one, a certain percentage of patients, maybe up to 25 to 50, may bounce into a second one within a short period of time also, within a few months.
Okay.
And, at that point, it's helpful to know, is it the same bacteria? Is it a different bacteria?
Yeah.
Was it something that initially maybe just, it was treated, but maybe not fully treated, eradicated, and then kind of came back over time? Or does it really represent a new episode?
Okay.
And so it's very helpful if you come to a specialist, if you have those actual urinary cultures in hand, because oftentimes what happens is that when you go in for what seems like a simple problem to your primary care doctor or urgent care or wherever, and they dip your urine, all they're really doing is a screening test.
Yeah.
And so they can look at that screening test and say, yeah, with X% probability you have an infection, but oftentimes they don't take that next step to send a culture. And to be fair, it's not always necessary, but in hindsight, for a provider like me as a specialist, if I have those cultures, I can start to understand really if that's what's going on, and again start to break out, is it the same bacteria, is it a different one, does it really represent an episode of a UTI, because there are also a lot of symptoms that mimic a UTI and aren't, and of course you don't want to just be throwing antibiotics at somebody who doesn't really have an infection that may have a UTI like set of symptoms, but it's something else.
Okay, so this is really important because I think a lot of times caregivers who are caring for their loved one with dementia, they'll notice maybe some UTI symptoms happening. They'll take them to the nearest urgent care center. Perhaps their loved one has had several UTIs in a short period of time, but the providers are always different. It's maybe even not necessarily the PCP that they go to regularly, or even if it is, because they're not the specialists, they're not thinking of those other options besides an antibiotic that could be ruled out. So for you Careblazers listening, this is something to really pay attention to, because you could either ask your primary care provider for such a referral, or at the very minimum, make sure you can ask for the specific culture results, and then go to a specialist to kind of get this further investigated if the repeat UTIs are something that's happening for your loved one. So that's really good to know. Yeah,
absolutely.
Thank you.
Yeah, that's definitely, as a specialist, one of the number one things that we can do is having more information, especially if you suspect that's something that's going on, because the more information that we have up front, the quicker the management can be in the long run. And I certainly don't want to minimize, by the way, the role of antibiotic use, because clearly, once an infection is established, it is an important role. And ultimately, if you are diagnosed with what we consider as recurrent UTIs, some percentage of patients are able to sort of manage it with those modifiable factors, and then some people, we do what's called a low dose of antibiotics, which means that you'll take a fraction of a full dose, but you'll do it every single day for maybe months, actually. And the idea there is to kind of just sort of go into prevention mode and kind of keep those bacterial counts down for a certain period of time. And sometimes that's what we end up doing with patients. But again, we can get to those endpoints and decide, which patients can be stratified accordingly if we have that information that you're recommending. Yeah.
That's interesting too, because for older adults, the medications get metabolized differently, excreted at differently. So when it comes to prescribing antibiotics, are there certain specific criteria or differences that you would do in prescribing an antibiotic for somebody who's like 80 versus somebody who's 30?
Absolutely. And this is something that actually, is you have to learn a little bit as you go. Interestingly enough, when we're trained in OBGYN, so many of our patients are younger patients. And then, when I did my fellowship, we all of a sudden start seeing a lot of patients at, through their aging lives. And then, of course, when I got out into practice, I'm actually, one of my sites is based right next to a retirement community. So anyways, it's an interesting learning process, but there is a bit of a difference because, as you mentioned, patients may have other medical problems, that we have to consider, other medications that antibiotics can interact with. our kidney function, which is what helps sort of process a lot of these drugs, may be altered. And then specifically in the urinary tract infection group, there's a couple of antibiotics that don't really concentrate very well in the bladder once you get over the age of 65. Now, we still use them sometimes, and we have to use them sometimes, but the dose may need to be altered, and certain side effects or certain things may need to be discussed with the patient or family with regards to that antibiotic to be cautious about. In general, for urinary tract infections, there's probably 4 or 5 go-to antibiotics. And oftentimes I'll get a patient that comes in that maybe had a sinusitis last week with their primary care, and they're on something when they see me, and potentially, I look at their lab data and say, look, you might have a urinary tract infection. We send it for a culture, and when we call them and say we need to add an antibiotic, there's often some discussion about, well, I'm already on an antibiotic for my sinuses. But one thing that some people don't realize is that the antibiotics have different coverage specificities.
Okay.
So I always say to people, one antibiotic isn't going to knock every bacteria out.
Got it.
So there are some, because the urinary system has certain bacteria that tend to hang out down there, it's not going to be the same bacteria that hang out in your sinuses. And so oftentimes, you will get a second antibiotic prescribed because the antibiotics that we're working with in the urinary system are very specifically focused to the bugs that are down there.
Yeah.
And again, once you have a culture result, it actually will do what's called a sensitivity to the medication also, which tells us, yes, this antibiotic's going to work on this specific bacteria. So it's a very specific test to, your bacteria, your infection, and then the drugs that we want to try on you. So that's another benefit of a culture, is that it gives a sensitivity report. So so we'll often, look at that sensitivity report, modify accordingly if we need to, and then based on the patient's age, other medications, other medical factors, and then any renal function to consider, and then make an antibiotic choice. So it's a somewhat simple problem that we think about. UTIs, especially as we get into an aging population, can be a little bit more complex because of these different factors.
Absolutely. That's exactly what I'm taking away, and I'm hoping all of you at home are taking away too, that a UTI doesn't necessarily mean just another trip to urgent care or PCP to get a antibiotic. There's a bunch of different considerations to be made just based on age alone, based on the specific culture that gets back. So definitely be asking for that further workup or referral to a specialist if this sounds like something that you're struggling with often. Now, you mentioned a couple minutes ago something about there are signs that look like UTI but aren't necessarily UTIs. What would those be?
So when a patient presents with a classic UTI symptom, they complain of pain with urination.
Okay.
They may complain of pain that's down in the deep pelvic area, not up here in the abdomen, not necessarily by the belly button, but kind of deep down in the pelvic area, sort of by that pubic bone area. They may have some back pain, plus or minus. They may feel like they have to go to the bathroom really frequently, quickly. Their incontinence, which could be a whole nother topic, may go up, and they may be wearing or having more leakage episodes, wearing more diapers. They may get an odor. So, there's sort of a set of 6 or 7 classic symptoms. Now, interestingly enough, as we get older, those classic symptoms start to fall off a little bit. They're not as necessarily, they're not as either easy to recognize, or they don't always come about. And that's another common complaint we get is, geez, my mother was doing fine, and then boom, the next time, we talked to her, she was a little off, didn't remember things as well, and then she was in the hospital the next day. And sure enough, had a urinary tract infection that had spread. So, but the classic symptoms also overlap with some other conditions. So I'll give you a very straightforward example. Just that thinning and chronic irritation of the tissues that we talked about from the lack of estrogen over time can cause UTI-like flares. There's a lot of estrogen receptors in the bladder, in the urethra, in the vaginal area. The nervous system in that area shares a corresponding sort of similarity in the back, and then how it's processed in the brain. So, there could be referred pain patterns. So just having some discomfort down there can then set off a series of symptoms, and then again, it looks like a UTI. So it's important to really try to differentiate some of these other potential causes from a UTI. And again, that's why a lot of specialists really demand, that we get a urine sample when you're having symptoms, we get the culture going, and not just call in antibiotics, for instance, because of course we get a lot of requests for that, and it's frustrating, and patients know their bodies. I mean, that is one thing, but we see a little bit of everything and kind of the gamut. So we're very careful to not just, want to throw an antibiotic at something that could be something else.
Sure.
And as we get older, again, those symptoms start to sort of converge, with each other. And so it can be difficult to appreciate it. And, we believe our patients, but we just know that there's, more that can be going on than meets the eye. And we want to make sure we're treating the right thing.
Absolutely. It's almost like short-term versus long-term benefit. So I'm sure, like for a lot of the Careblazers out there, like it's hard to get their loved one to go to the doctor a lot of times. It's like a big ordeal to get their loved one to go there. However, if this is something you're constantly battling with, getting that specific information, that specific, evaluation with possible treatment other than an antibiotic could prevent this from being an issue that you constantly need to call up and ask for an antibiotic. So it would be definitely worth it in this situation.
It's worth putting in the work up front, like you said, because otherwise, the downstream effects, as you mentioned, could be that, geez, you're seeing that your family member is, constantly on antibiotics, and you have to worry about resistances, and you have to worry about drug reactions and allergies and, stuff that we see from people being on antibiotics all the time. Also, like you said, it's a lot of work, but if you put the work in up front, it can save you time in the long run, and potentially some, downstream hospitalizations or other problems. Because, one of the things that we do see in our clinic so many times is that, because the urinary tract infections don't always present the same, or if you have a loved one with a little bit of cognitive decline, memory problems, self-care difficulty, that a lot of times they do present later in the game, and then they're sick.
It's serious.
It's serious. That's right. Then, like I said, the next step may be, geez, my loved one was a little off one day, and then you're in the hospital 3 days later.
Exactly.
And then it's a week of being in the hospital, and a lot of times, sure, we can get them out of that, and they'll recover, but it's a big deal, and it can be life-threatening. So it's important to try to recognize those things early. But it is going to be different in some of those patients. Sometimes it's just an odor of the urine.
Yeah. So whenever there's like a strong urine change of smell, that would prompt an idea,
an evaluation at least.
Something needs to go on. Okay.
That's right.
And with dementia, a lot of the symptoms, sometimes that happens in dementia, especially if your loved one is one of those who has a lot of behavioral issues already. Sometimes it's easy to miss a UTI because you're just assuming it's part of the dementia.
That's right.
A lot of the Careblazers are really good, though. They'll be like, oh, all of a sudden my mom was just totally, she had the worst day of her life last night. And it's like, okay, immediately they're asking, check for UTI, check for UTI, and that's great.
That's right.
Get from your symptoms too, talking about, some of that like deep abdominal pain that they might be experiencing. So for you Careblazers at home, it might be if you're observing physical signs of pain as your loved one's using the restroom, or maybe your loved one's using the restroom way more frequently, or showing like messing with their pants or messing with their undergarments more frequently. That might be a sign that to prompt evaluation for a UTI, kind of catching it earlier in the process. So it's just so hard because, and especially, well, you mentioned like incontinence could be a whole nother topic. Like if your loved one's already incontinent, which I would imagine would make you a higher risk for UTI too, because you're kind of sitting in that.
Yeah, that's kind of a heated question actually, but there's probably no doubt that it doesn't help. It doesn't help, So it's a big circle, because what happens is that urinary tract infections are a cause and a worsening of incontinence. But at the same time, like you said, if you're already incontinent, then, sitting in a diaper or a pad for long periods of time, potentially just the moisture even, the moisture down there kind of setting off those bacterial environments that are normally kind of in equilibrium, setting that off. I mean, the incontinence itself isn't a cause of the UTI, but setting off that environment can be. And then sometimes skin breakdown occurs with a little bit of the wetness. I mean, it can be very challenging, for a severely incontinent patient to especially with a caregiver, to keep up with that. Almost impossible, really. So what we try to do to put that puzzle together is get the UTIs under control so that we're not exacerbating the incontinence, and then just aggressively treat the incontinence. And we can't make everybody dry, but but we could try to improve it. So exactly, you know, so we try to take it in you know, in a holistic picture and try to tackle one thing and then come back and tackle the other. So but yeah, it definitely does not help.
Yeah. And as you at home are probably already aware, it doesn't take much for like one little thing, or I don't want to say little, but one symptom to all of a sudden start snowballing into a bunch of different problems. Right. Incontinence to skin breakdown to, you know, who knows, it just goes on and on from there. So again, earlier identification, earlier treatment is going to make it best overall. Absolutely.
Absolutely. This is just such an important topic. I mean, we see this, I probably see this, I mean, as my number one or number two problem, you know, in our clinics every day.
Mm-hmm. Now, any idea why a UTI symptom would create that confusion in older adults versus like a younger adult? I don't think that's as common of a symptom.
I think that, you know, if you look at infections as a whole, you know, whenever somebody, as a you know, patient ages, gets a little bit older, anytime you get an infection, whether, you know, it's a pneumonia or again a bronchitis or maybe a GI illness, you know, the altered mental status or delirium state, and of course I'm not an expert on that, she is, you know, becomes one of those things that pops up. And, you know, off the top of my head, mechanistically, I'm not 100% sure. I can say that, you know, certainly in our populations, you know, if a UTI does go into a kidney infection that's more serious, you know, you could have things like fever, which can alter, you know, and cause delirium. You can also have, you know, a blood infection, which is called sepsis, which again, you know, is going to be, you know, your whole body is then secreting these inflammatory products. Your body's trying to fight the infection. You're probably definitely getting febrile at that point. And so these more serious infections tend to cause delirium states. And again, maybe you can help me have this discussion here in a second. But the UTI itself, you know, just representing an infection, you know, and so that sometimes, as we get older, you know, your body's taking care of it in slightly different ways. Your immune system's not working exactly like a younger person is, and it can definitely get to a more advanced state quicker than somebody who's younger. And I think that's one of the basic issues.
Yeah, I agree. Like the older you are, your body is struggles a bit more to fight off the basic things that like younger people's bodies are able to fight off a bit easier. And so any little slight change in the environment or any little thing that's off, like we were mentioning earlier, it's just that kind of snowball effect.
That's right.
So definitely more susceptible that way. Now, what are your biggest recommendations for how to prevent UTIs?
So I think that, you know, for women, there's some simple things you can do every day, you know, and we've touched on a lot of them already, but to sort of sum it up, you know, number one, you know, make sure you're getting some regular health care if you can be. And again, it's a challenge for patients who have, you know, cognitive problems, and if you're a caregiver, but hopefully you're in regular touch with your primary care doctor. And then the next thing would be, you know, to try to have adequate fluid intake. What the fluids do is that they, you know, especially things like your water and the healthier type of fluid intake will help flush the kidneys out, and the more you can actually flush the kidneys, then the urine comes out of the bladder, and then you're not likely to have stagnant, you know, sort of concentrated urine that might like to harbor bacteria. So good, you know, good fluid management. And on the flip side, this becomes tricky for patients who are incontinent because we're often telling them slow down on fluids.
And I'm just thinking too of a lot of my older adults who just like want to drink coffee all day, every day. Like that's probably not a good thing if they're struggling with like recurrent UTIs.
Coffee itself is not bad for, you know, UTIs per se, but it is a little bit of a diuretic and it's a bladder irritant. And so actually one of the things we see on the flip side on the incontinence aspect is that, you know, any little bit will just tip you over the edge. So, and there again, you know, what that's playing the role in, you know, you're wetter, you're having more incontinence episodes, and then it goes back to the UTI. So again, that cycle. Pushing healthy, good fluids to try to balance it out with the other issues. I mean, some people have heart issues that they're fluid, you know, restricted. So we do have to be, you know, careful about, giving general advice, obviously, but again, in the context of a healthcare provider, try to be cognizant of your fluid intake. Cleanliness is important. It's not going to be at the 100% end all, but if you have have to wear a diaper and you have some urine or bowel accidents, again, it doesn't have to be perfect, but trying to keep up with that to the best that we can will minimize it. Interestingly enough, we haven't talked about this, the bowels, the intestine health is very much linked to the bladder health. And again, it's a system that's close to each other. So for people who have a lot of constipation, that's another risk factor, which is a big deal for patients as we get older. Or on the flip side, diarrhea. So people will often sort of ask about both of those. And what happens is that in a patient who's constipated, oftentimes their bowel bacteria gets off. So whatever the normal is for them, over time, if you're constipated, your GI system isn't quite in that right symbiosis. And so then you're often harboring bacteria that your body's not used to. And then again, when you do have a bowel movement or you do have this or that, you've got these bacteria that your body's not used to fighting. So constipation, if you can take care of it, or again, on the flip side, loose stool, diarrhea or loose stools, trying to manage that. There are different techniques. Again, it's a whole nother topic we could talk about. I see that all the time as well.
I think we'll have her back on the channel in the future.
Lots of interesting stuff. But try to regulate your bowels. The simplest way to regulate your bowels is fiber. Okay, so that's the simplest way. Now, fiber doesn't work for everybody. It can actually make some people worse, but not to make it too complicated. Fiber is pretty simple. It's pretty safe. It's easy. A lot of people think they're getting enough fiber in their diet. They say, well, doc, I'm eating a salad and I eat an apple, and then an orange at dinner. But we really need 30 grams of fiber. Wow. And I don't know how to measure out 30 grams of fiber. That's a challenge.
I'm probably deficient.
I know I am. When I was growing up, my grandmother would drink Metamucil every day. So I used to think to myself, wow, when you get old, this is what I thought as a kid, when you get older, you have to drink this stuff that you stir up. And, I started it like 5 years ago. So, these things kind of sneak up.
You're old now.
I know, that's right. Apparently I'm old. These things sneak up on you. And, again, it's a challenge. So if you can incorporate some of those things, that's really neat. Simple. Again, it's something that you have to find what you're going to tolerate and what you can do on a regular basis. Because part of health maintenance also is being consistent. And that's a big problem. And it's so hard for patients who have caregivers because, you already have 100 things on your list to do. 100.
Absolutely.
I mean, so when you're talking about, okay, now I got to add this thing into the routine and this medication, I mean, it becomes very overwhelming. So, anything you can do to simply break it up and say, as part of we have breakfast every morning together, we're just going to have a little glass of water, do the Metamucil, and, simple.
Absolutely.
So in any case, bowel control is one thing. Then the next thing I would say as far as UTI, since we kind of keep getting off track here, is again, if you're a candidate, you're a female candidate and you're after menopause, consideration of thinking about vaginal estrogen. And there's a way to do it. Estrogen's very, very controversial over the years. The pendulum swings from, everybody's on hormones to nobody's on hormones. But vaginal estrogen is very safe, and it's a different product because you're not taking a pill, you're not putting a patch or a cream on your outside skin, you're directly placing a small amount into the vaginal area. Okay, and what that does is it treats the area locally and takes care of that thin skin, the dry cracked tissue. It increases blood flow. It helps the good bacteria balance come back into the norm. The more good balance you have in that area, the better off you're going to be. I mean, still some people will get UTIs, but you're trying to go into prevention mode as opposed to treat
exactly
mode.
Now, is that something that's usually taken care of with one treatment, or is that something that you do long term, or does it just depend, like most things?
Most of the time you need to apply vaginal estrogen regularly. So again, it's one more thing to do. And we see it in our clinic all the time that I might have an 85-year-old patient. There's no way they're going to be able to take a little cream and put it inside. But again, depending on the level of and comfort level of the caregivers, a lot of times they're already changing diapers or they may be helping with toileting. Something simple that you can do is, there's an applicator that comes with it. You can do finger application or an applicator and just inserting a little bit into the vaginal space. But it's a regular maintenance, just like anything else, kind of prevention mode, because again, if you drop the medication off, then the estrogen level drop again, and then the tissues kind of go back to being less estrogenized over a period period of time. But it's simple, it's safe. A lot of people worry about cancers, things like breast cancer, uterine cancer. On the label of estrogen, there is a big FDA warning for blood clot, heart attack, stroke, and the cancers we just mentioned. But if you really look at the evidence that's available now, and it's accumulating every day, that label was based on the pills that were made from 50 years ago.
Yeah.
And number one, the doses were much higher.
Yeah.
And number two, the way the FDA does it nowadays, and we're legislating to change this, but the way they do it is that anything that has a certain medication, it has to be mass labeled.
Yeah.
So even though the vaginal estrogen studies, the research that's been out, shows no link to breast cancer, no link to other types of cancers, blood clot, heart attack, stroke. I mean, even though there's really no link to it in the studies, the FDA still has to label it the same. So
I say for most of those side effect inserts, if people read all of them, nobody would take any medications, right?
Nothing.
So
the Tylenol warning is the worst.
Oh, I know.
If you look at Tylenol, I mean, so.
Yeah, and I mean, obviously, talking about, I deal a lot with obviously dealing with the behavioral challenges of dementia, and I'm a huge advocate for let's try those non-medicine approaches first. That's the most beneficial, most effective, less side effects. That's always my go-to. However, in those cases, and you guys know it, where you absolutely need those medications and they're a lifesaver for you, I guarantee if you read those side effects, it'd be the same kind of scariness factor. So that's good that you say that. What I really took away from this interview is something so simple with the UTI.
That's right.
That you just think needs an antibiotic. There's so much more involved, and the importance of getting a specialist if you need one, or at least having that open conversation with the PCP in terms of, hey, this is going on frequently, what else can I do? Is there anything that is a huge thing I'm taking away from this interview. I'm sure you are as well, that I don't think most of us really think about. We just think of UTI as something simple and easily treatable, but
that's right.
Yeah.
And there again, you can take a topic and delve into it as much as as far as you want to go, and for a lot of women it is something simple, which is the nice thing, obviously. But as we age, some of these things that are sort of simple problems potentially when we're a little bit younger can become clearly a big issue, can become life-threatening, and can just lead to one more thing that the patient and their caregiver is dealing with, and it is something fairly treatable. We can't always, I get some patients who come in and, certainly, they're frustrated because they've gotten back into one of those cycles where they're bouncing in, or, we have them maybe on maybe some of those more serious patients have them on some antibiotics for a while, and I say, okay, let's try without, and 3 months later they're back in the same cycle. I mean, some of these things we're still understanding scientifically, so as we get more information, it's an evolving science, but certainly, the good news is that it is fairly treatable, and it can make a big difference for people. Another thing we didn't talk about that, just to bounce in, because I get this question all the time. Okay. What about cranberry supplements? Because that's a big one. That's a big one with UTIs. And actually, the good news is, because I love cranberry, the good news is there is actually some data that's accumulating to say that it can be helpful. Okay. There's no reason to think it would be harmful. However, I do tell people, that juice, I mean, the cranberry juice, probably not the best thing. I mean, you've got sugars, and we don't really know how much cranberry is in there. So it's probably not the best way to go, but there are cranberry pills on the market. So you can take a little pill or tablet. Now, the downside of the cranberry pills is that they don't always tell you how much of the active ingredient you're getting. So what they do is they label cranberry extract 100 milligrams or 200 milligrams, but there's actually an active ingredient within the cranberry that you need to remember. It's called PAC. I'm not even going to try to say the full word because I trip on it every time, but it's, remember, just PAC.
Okay.
It's like procyanothiodins or something, but
there you go.
I'm not even sure that was right, but PAC, and that has been studied that in doses of 36 milligrams, the PACs, that can be helpful in actually keeping the bacteria from adhering to the bladder wall. So we're not looking to acidify the urine. That's a common myth. I think, well, cranberry will acidify the urine. It's actually not acidification. It's that these PACs keep the certain bacteria from potentially adhering to the bladder wall. So if the bacteria do make it into the urinary tract, which they will at some point,
Yeah.
it can help keep that down. So when you're looking at a cranberry extract tablet, it doesn't always tell you the PACs.
Okay.
And I can't, as a physician, and nobody could even read. I've checked out multiple brands. You can't tell if 100 milligrams of cranberry equals 10 PACs or 100. Now there is a brand out there, I won't mention any names, that has 36 milligrams of PAC that I often tell my patients about. However, there's a cost to it. So, that's one downside. But there are some things that, if you do enough research, that there's some products out there that you could potentially do. And so again, the evidence is mounting.
Yeah.
And one of the things I like to tell people, is if they want to run something by us, I'm all for it as long as it's not harmful.
Yeah.
Because I don't always know. We don't always have the data for things. There's always new products out there, advertisements, bladder health vitamins, and different things like that. And I can't always tell people if that's going to be helpful or not. So oftentimes the only thing I could really do is sort of look at what's in it, and then we can assess, well, is this going to be harmful?
Yeah.
And as long as it's not, certainly a lot of times we don't mind trying it.
Yeah.
We just don't know how much of an effect it has. So if you're going to put your money somewhere and your time and take an extra pill, maybe you want to do something that, it has a little bit more scientific evidence.
Exactly. So speaking of the cranberry pills, I know that evidence is just starting to mount and there's still a lot of unknowns, but could that potentially be another potential prevention?
Absolutely.
Okay.
Absolutely. So again, we sort of started off with some of these things out of order, but absolutely. So again, that we were kind of coming around full circle to, simple things that you can do, hygiene, modify, watching your fluids and making sure you're kind of fluid appropriate, doing anything you can to minimize incontinence, bowel habits. We talked about that. Things like simple for women, vaginal estrogen, if you're a good candidate. And then, cranberry. So those are kind of some simple things. And we haven't even mentioned antibiotics yet, right? That's last on the list.
Exactly.
That's last on the list. So, and again, some people are going to need that antibiotic, and that's okay.
That's okay. What they're there for.
That's right. So, that's what they're there for. But we try to do as many things as we can to, to optimize before we can get to that phase.
Awesome. Now I'm going to put you on the spot here.
Okay.
So, kind of switching subjects, but I'm going to do an interview, a video on this topic in the near future because a Careblazer asked me a really important question, and I'm thinking specifically I could apply her question to pelvic exams or pap smears for females.
Okay.
At what point are those things not need? I mean, the last thing an older adult with dementia needs is another unnecessary test.
That's right.
So is there a guideline specifically in your field where that kind of thing would just stop, that it's no longer needed?
So that is an amazing question because, it's a moving target.
Okay.
So, like anything in medicine, as we get more information, as we get more research, as we understand these disease processes better, things are going to be a little bit changing in terms of the guidelines. Yeah. So one of the things, and I see a lot, most of my population is older patients. They often come in and say, hey doc, can I get a pap smear today? And I'll, look at their age, and, that's the first thing, by the way, that determines whether or not they need a pap smear. But, really, when do we stop doing these things? And let's differentiate too really quickly what's an actual pap smear versus a pelvic. Okay. So the first thing is a pap smear, which is what many women, we all grew up doing every single year, is actually a test of the cervix. Okay, and the cervix is the area that dilates when we have babies. It's attached to the uterus, which means that if you've had a hysterectomy, most likely your cervix is out. Okay, so first of all, as soon as you've had a hysterectomy, most likely your cervix is out, and so you don't have anything to pap.
Okay.
You can pap the vaginal wall, but only certain patients need that. Okay, so let's take apart people who have uteruses versus people who don't as far as paps go. So the current guidelines say that at the age of 65, if you've had 10 years of normal pap smears, now that doesn't have to be every single year, but let's say the last 10 years, if you look at the last 10 years, if you've had a couple pap smears in that 10 years that have been normal, you can stop paps at 65.
Interesting.
Okay. Now, let's move on to the idea of what is a pelvic exam and how is that different than a pap? Well, a pelvic exam is a general examination that starts from the outside of the skin and then maybe involving like a speculum exam to look at the walls, of the vagina. Maybe visualize the cervix, or if a patient's had a hysterectomy, just visualize the back of the wall. It may involve, touching or palpating the skin and the vagina near the bladder on the outside. We call that a bimanual exam. So a pelvic exam is specifically an exam that, looks at the outside, the inside, and you're feeling for, cysts, masses, anything that could be different. So pelvic exams can be done after the age of 65, maybe every few years. And then again, what's the arbitrary age of saying, do you ever need a pelvic exam again? It can be based on symptoms.
Yeah.
And what they're saying now is, sort of individualize that with your primary doctor, or if you have a specialist for some reason that you're following, because certainly, the more difficult it is to get up on an exam table, and these women exam tables are not easy to get up on, I know that. But the more difficult it is, you have to get undressed, or get help to get undressed, right? It's a private sensitive exam. Sometimes those areas are a little bit, they're sensitive as we get older. And so, it's not a comfortable exam. And so, we want to basically take a patient after the age of 65 and kind of individualize what their needs are.
Awesome.
I will tell you, though, in general, to kind of summarize this, so look at that 65 as kind of a critical number. And again, it's a moving target, so it could be different in 6 months from now. But around 65, have you had normal PAPs? So if you have, maybe you don't need, maybe your doctor and you don't need one. If the PAPs are abnormal at any point, they may extend that, though. Okay. So again, normal PAPs, maybe you don't need a pap smear, but then your doctor may say, well, come in every couple years and let's just look at the vaginal skin. Let's just look at the outside. One of the things I tell my female patients is, unlike men, we can't look at ourselves very easily, right? We have to get into a Cirque du Soleil move, and get a mirror out.
A little flexibility.
And to see those areas. So having somebody place eyes on that every few years, because they say, well, my parts are all out. I had a hysterectomy, my ovaries and tubes are gone. I don't need anything. Nothing can go wrong. And the reality of that is that's far from true. I mean, obviously you're lower risk, but somebody should, potentially, as long as you're mobile and as long as you have care, within every few years, it doesn't hurt to have somebody look at at minimum the outside and maybe do a very gentle inspection inside. And so I tell my patients, let's do it every couple years. Have somebody take a look. Otherwise, nobody's looking down there because we can't. So that's my kind of basic guidelines. And then the official guidelines also say, of course, based on symptoms. If a patient that's 85 is asymptomatic, meaning they're stone cold normal, they're healthy, they're in their primary care's office, and they have no complaints, and 5 years ago they got their last pelvic, do they need one today? Probably not. Probably not. So
awesome.
Yeah, excellent question.
Thank you for entertaining that. It's something I've been spending a lot of time thinking of recently, and I appreciate the individualized approach too, right? Because a 65-year-old with dementia in the moderate stage who's non-functional, non-ambulatory is so much different than a 65-year-old who is still working and functioning and driving. So it's not,
and maybe active.
Exactly.
And that's right.
It's not just the age is one of the considerations, but it's not just that. You have to look at all the other factors. So sometimes when you're going to a PCP or anybody and they're just kind of saying, you haven't had this year, or you haven't had this year, it's like, there's a little bit more of a thought process there that should happen, because you certainly don't want to put your loved one through anything they don't absolutely need, especially if it's going to cause distress. But we also don't want to give the impression that once you're old, you don't get any tests. Like, that's not the case at all either.
Exactly.
So I love the individualized approach. So.
Exactly. And I think that's a good point, is I think our primary care doctors, they're in the front lines. They're doing the really hard work. Our geriatricians, our people in psychology that are out there in the homes. I mean, our caregivers, I mean, by the time you get to the specialist, clearly there's some symptoms going on. There's something going on. So you're probably going to get a pelvic exam. But, again, and that doesn't stop me. I mean, I have a lot of questions about, well, geez, I'm 90, doc, so, I don't need to worry about it. And again, it's really an individualized conversation, because like you said, I have 90-year-olds that they're running around faster than I am.
Oh my gosh,
and they're very active and physically and maybe intimacy-wise. And then, like you said, I have 65-year-olds who are a lot in a much different curve. So, it is important to individualize it and just ask questions, because the biggest thing at the end of the day is certainly as a physician, we're required and asked to follow guidelines, and we want to do our best to do that. But those guidelines are also for populations, right? And so we want to look at the person, from head to toe, and their situation socially, mentally, physically, what their desires are and their needs are, and take that into context.
Absolutely. Awesome. How awesome was she, Dr. Klauschie? This was such a helpful interview with a lot of information, and I really appreciate all the time you took to do this.
Absolutely. Like I said, invite me back and we'll talk about more topics.
Yes.
I love this stuff. I really do. I'm very passionate about it. There's so many different aspects. I had no idea when I went into OBGYN that I would be spending so much time with a group of patients as women were aging. I really didn't know that, because in OBGYN traditional training, we're delivering babies for most of our time. So again, it's a lot of it's learning on the go, the extra 3 years of training. But I love it because as patients get older, and there's all these family and care considerations. I have a special place in my heart for that, because I have some siblings with disabilities. My parents have been elbow deep in caretaking, and so have I, alongside with them since they were little. I really love being involved with that aspect. And patients, as they get older, as an aging population, they're just so appreciative. They're so grateful. They have perspective on life. I mean, it's the best population.
Absolutely, I agree. It's the fastest growing population too. And unfortunately, our society and our medical community in general, psychology community, like our studies, our guidelines, our everything that we've based all of our practice in, so rarely included older adults.
Exactly.
So we're taking information and recommendations and guidelines that's really based on a younger population, and we're doing our best to apply them to older adults. So that's why it's important to get informed. It's important to be comfortable with your primary care provider or all of your medical providers, and be okay asking questions. Like, it's okay that not everything is textbook by the book. So thank you so much for being here.
You're welcome.
What questions or what comments do you have for Dr. Klauschie or I? Would you like to have another interview? And if so, what specific topic or questions do you have? We would love to have her back on the channel. Go ahead and leave them below this video, and I will be back next week, Careblazers. Bye.
Thank you.
Careblazer, how awesome was that video? So informative, so helpful. I'm so grateful that Dr. Klauschie shared her time and her knowledge with all of us. Now, I know that we've covered a lot of information over quite a long time, so I put together a helpful handout that I will link below this video, going over the main signs, the main tips for treatment and prevention of UTIs, so that you can go ahead and download that for your own records in case you want to reference any of the helpful information she provided in the interview. All right, Careblazers, take care. Bye.